The committee is called back to order. By agreement with my colleagues, we're going to resume. I understand Mr. Miller will be joining us shortly, but I recognize Mr. Andrews for 5 minutes.
Thank you, Mr. Chairman, and welcome, Madam Secretary, to the committee. It's very, very wise, Madam Secretary, to be listening to Chiquita. I would too. She's a very able and wise young lady, and from the right state, I might add. Madam Secretary, one of the topics of the moment for the country is Medicare and how we should respond to the long-term bargain our country made with our seniors and persons with a disability in 1965. And that bargain, of course, was that when the person retires or is adjudicated to have a disability, they will be guaranteed medical benefits, they'll be guaranteed the choice of their own physician, and Medicare will pick up the lion's share of that bill. And that's a system that I think has worked very well for this country for a very long period of time. As you know, there are proposals that would, in my view, end that system. It would say to people 55 years and under that they're going to be into a very different system that is essentially a subsidy, an inadequate subsidy, to buy private health insurance. The report that Mr. Miller spoke of earlier indicates that if one takes the gap which the Congressional Budget Office has identified between the premium support that the Republican plan would offer and the real out-of-pocket costs for health care for retirees and seniors, it would be about $6,000 a year. And for a senior to have enough money to cover that gap, he or she would have to save nearly $200,000 out of their pocket before they retire. One interesting point of reference is that the average 401k balance for a person when they retire in this country is a little less than $100,000 a year. So what that means is if you are a senior under the Republican Medicare plan, at least the one that existed until yesterday, and you emptied your 401k, it would only make up about half of what you need to pay your out-of-pocket health care bills, additional out-of-pocket health care bills, because of the Republican plan. Now, I know that before you came here, your experience as governor gave you, and back in Kansas generally, gave you the opportunity to be an insurance market regulator. I wonder if you could tell us what you think would happen, in addition to this financial disaster, what you think would happen to people 65 and over and people with a disability if they were thrown into the private insurance market with this kind of inadequate subsidy. What would that mean to a senior citizen or a person with a disability?
Well, Congressman, I've seen the same analysis that you have. First of all, Medicare as a program has one of the lowest administrative costs of any health program, I would suggest, in the world. So we know that according to CBO, according to any economist, that the administrative costs of an average health insurer are significantly higher. So you take the same amount of dollars and you have less buying power if you're doing it through the private market than you do through Medicare. Secondly, to have a fixed dollar amount as opposed to guaranteed benefits, I think is, as you suggest, a very different kind of commitment to seniors and leaves an enormous cost shift onto seniors and those with disabilities.
If I just interrupt for a minute, what might that cost shift and lack of guaranteed benefit mean for an oncology patient, a person with cancer? Give me an example of what it might do there.
Well, I think there's no question if you take a snapshot, people will run out of money very quickly. And if you run out of the government voucher and then you run out of your own money, you're really left to scrape together charity care, go without care, die sooner. There aren't really a lot of options. But it's estimated, according to the CBO analysis, that by, I think it's 20 2030, you would have about 70% of the cost of medical care shifted onto individuals, a pretty dramatic. Right now, it's about 25-75, and that would flip pretty dramatically. And most people, or a number of people, working families and others, don't have the wherewithal to come up with that kind of cash, particularly in their later years when they're likely to have more serious and more expensive care.
It's true, isn't it, that the Republican plan that was adopted by the House majority about 2 weeks ago really isn't a cost reduction plan, it's a cost shifting plan. That as health care costs go up, seniors pay more and Medicare goes away.
Well, I think the combination of the votes on repealing the Affordable Care Act, which would not only get rid of the new tools we have to crack down on fraud and abuse, but limit the eliminate the closing of the donut hole, go after some of the new guaranteed benefits, combined with the voucher program, would basically destroy the commitment to ongoing health care. As you say, one of the promises made in 1965, and a little personal anecdote, my father was actually on the Energy and Commerce Committee serving in Congress and helped to write the Medicare law. He just had his 90th birthday, and he's pretty happy with those benefits right now. And
we'll tell Mr. Dingell that.
Absolutely. Well, he served with Mr. Dingell, and he knows Mr. Dingell.
So do we all.
Everyone has.
Yes, indeed. But I think it's a very different kind of commitment that we would be making to 55-year-olds about their future in the United States.
Thank you, Madam Secretary.
Thank the gentleman. Mr. Wahlberg, you're recognized.
Thank you, Mr. Chairman, and thank you for joining us, Madam Secretary. As you may probably already know, since 1992, the National Institute for Occupational Safety and Health and National Cancer Institute have been working on a study to determine the potential health effects of diesel exhaust on miners. Members of the mining industry voluntarily provide NIOSH with access and information to conduct this study. Initially, NIOSH agreed to share data with the companies and volunteered access and information. However, since that time, NIOSH has not honored that agreement on more than one occasion. As a result, federal judges have twice ordered NIOSH to share these materials with the concerned parties, which include this committee. Yet full compliance has yet to be seen. And so the questions I would ask I'd like to know why NIOSH has not complied with these orders of 2 federal judges, and would also like to know what assurances you can give me that the data will be released as required by the courts. In other words, basically, do you want NIOSH to comply?
Well, Congressman, I must confess I am not familiar with either the studies that were done or the federal cases, but I will commit to you that I will learn about them quickly and work with you to get you the information that you've requested. I just can't respond about why they haven't done it. I wasn't aware that they had not, but it will be something that I will.
If the court has ordered this, I would hope I can conclude that you would want them to comply.
Well, as I say, Congressman, I'm not familiar with the situation. I will get very familiar with the situation, and I will get an answer back to you quickly.
I appreciate that.
Yes.
Moving back to the Chairman's lead-off questionings with Head Start, last year the U.S. Government Accountability Office conducted an undercover investigation of 15 Head Start programs, acting in response to tips from former and current employees at 2 separate Head Start centers. Undercover GAO applicants tried to enroll children in these programs and presented the centers with pay stub data that demonstrated they were above income eligibility requirements. 9 of the 15 sites enrolled the students anyway by encouraging applicants not to submit the pay stubs that would put them over the income threshold. Some of the programs continued to count the students as enrolled, even though the students never actually participated in the program. At a May 2010 hearing before this very committee, the Assistant Secretary for Children and Families stated that the Department was taking immediate corrective action and was undertaking a top-to-bottom review of its program oversight responsibilities. And so the questions I would ask are these. Can first you give us an update on the Department's effort to combat waste, fraud, and abuse in the Head Start program? And secondly, how many unannounced monitoring visits has the Department conducted since the release of the GAO report?
Congressman, I first of all want to tell you that I share your dismay at the GAO report, and more than the GAO report, the practices that were underway. And we do take program integrity very seriously. In fact, I have for the first time created a Secretary's Program Integrity Council, which operates across all of our agencies and departments to try and actually get out ahead of any practices, any lax oversight, any issues that we should know about. We did very quickly go into, first of all, we've had, I think I was told yesterday, 160 unannounced visits, to answer your question with some specificity about and those are ongoing efforts to make sure we're complying with that. We've conducted retraining of Head Start directors. We've issued new guidance on compliance with program integrity and guidelines, and reminded people about their legal responsibilities. We are recompeting, as I say. We put out a rule about recompeting the lowest 25% of the program. We're conducting overall reviews and ongoing training initiatives, but we're taking this very seriously, reminding people that these are taxpayer dollars and being used to educate some of our most vulnerable children, and we want to make sure that that's exactly where the dollars go.
Well, I appreciate that, and we'll look forward to receiving fuller information on that. But in a time of vanishing dollars for our educational systems, in my state as well as your state, we can't suffer this to take place. So thank you.
I agree.
Thank you, Mr. Chairman.
I thank the gentleman. Mr. Payne.
Thank you. Let me commend you for the outstanding job you're doing. And I think one thing we need to keep in mind is that it's great that the United States of America has moved into the nations around the world, developed countries, to provide universal health care. As you know, we were one of the only developed countries in the world that did not provide it. Let me just say about Head Start. We know it's a vital program that helps to level the playing field for low-income preschoolers and improve academic outcomes. We know there are some problems, but we're striving towards a more perfect union, so to speak. In your testimony, you mentioned the department's endeavor to strengthen Head Start programs, and I commend you for efforts as well as your continued support of childhood education and FY12 requests. My Republican colleagues proposed a $690 million cut to Head Start this year, as you know, which would have removed 130,000 low-income children and families from the program, closed 10,000 Head Start classrooms, laid off 33,000 teachers and related staff. This measure is contrary to our goals of increasing employment and strengthening educational outcomes. Thankfully, this measure did not become law, and our children, like a little fellow named Matthew in my district, sent me a constituent letter saying, "Dear Congressman, it's my future, hands off Head Start funding." Matter of fact, where's old Matthew's? Old Matthew had his little handprint and said, "Just keep your hands off of our funding." So I have to have a meeting with him. Hope he doesn't come to town hall meeting to run me out of the place. But so we know that it's very important, and so I really commend the administration and support your FY12 budget. Let me just say, in addition to proposing cuts to Medicaid, my Republican colleagues supported a spending plan that would turn Medicaid into a block grant program. Medicaid provides health care for the most vulnerable population, the elderly, disabled, children, low-income adults. Madam Secretary, can you explain the impact of this action? Would it have would have had other beneficiaries in states if it had gone into effect?
Well, Congressman, our analysis of the budget proposal is that, as you know, not only does it propose a block grant, but there's a significant and very dramatic decrease in the funding level. So it's a fixed cap that decreases over time. Frankly, again, as a former governor who administered a Medicaid program, one of the things that you can't anticipate is you know, 2 years out what the economic downturn is going to do. So just a little bit of hindsight, if we had had a block grant in place for Medicaid recipients over the last number of years, and the increase in services needed based on the number of people who lost their jobs, lost their health care, needed reliance on that, I think most states would have been in a more dire situation than they are right now. As you know, the vast majority of the Medicaid population are children. The most expensive part of the population are older Americans who are poor enough to qualify for Medicare, but often in nursing homes. And you don't have a lot of flexibility. The people don't go away when the money goes away. So I've met with mayors and some governors and county supervisors and others who find this proposal to be very alarming, because they will still deal with folks coming through the doors of emergency rooms without care. They'll be dealing with people in nursing homes without the support that Medicaid currently provides for that very critical nursing home care. What we think is a much more strategic way to deal with this is 5% of the Medicaid beneficiaries account for about 50% of the costs. They are the most chronically ill, often disabled. Many of them are getting very erratic care. They're often in two systems, Medicare and Medicaid, at the same time. And we are working very closely with states and with a proposal that's going to come out of our new Center for Innovations that will focus on the so-called dual eligibles and give states a lot of flexibility of using the best possible practices to coordinate care and actually drive those costs down. If we can cut those costs by 10 to 15%, states will save billions of dollars, and the federal government, frankly, will save billions of dollars.
Thank you very much. I don't know if I have time for another question. Well, still on yellow. During the debate in H.R. 1, Republicans adopted 9 riders intended to block implementation of all or components of ACA. If enacted, these amendments would have brought implementation of the ACA to a halt, eliminated benefits that people throughout the nation are already enjoying, including many of my Republican colleagues' constituents. Can you quickly mention some of the benefits that already have been experienced as a result of ACA?
Certainly, Congressman. I mentioned the children with pre-existing health conditions, which I think is a huge step forward for families who have been struggling with that, being locked out of the insurance market for years. We have already seen the reports of just the last month are that hundreds of thousands of young adults are now covered. One of the most uninsured populations in the United States is now coming into the marketplace thanks to the provision that allowed young adults to stay on a family policy for an extended period of time. We know that seniors are beginning to get relief from their prescription drug benefits. A number of them got the one-time $250 check, but this year they'll have a 50% decrease that's going into effect. And at the same time, they are experiencing lower rates on Medicare Advantage plans thanks to the negotiating power that the ACA provided for us. There's a new Bill of Rights for patients that ensures that new plans have preventive health care, that new oversight powers for state insurance departments to do rate reviews. The medical loss ratio goes into effect this year, so 80 cents of every health care dollar has to be spent on health costs and not overhead and CEO salaries. And those are just kind of snapshots of what's beginning to be underway. The pre-existing condition plan, where we now have 18,000 Americans who had been locked out of the market, are now able to buy market-based coverage and really often in life-saving situations.
Thank you.
The gentleman's time has expired. Dr. Desjardins, you're recognized.
Thank you, Mr. Chairman. Secretary Sebelius, thank you for being here today. And like my colleague from Tennessee, I'm also a physician, and prior to coming to Congress in January, I practiced primary care medicine for the past 18 years in Tennessee, and was also witness to the failed attempt at a government-run model in the state. Our Medicaid program was known as TennCare, and I would love to discuss that, but I think right now what's on a lot of people's mind is the issues with Medicare. So I would like to start with that. Would you agree that Medicare is an example of government-run health care?
Congressman, Medicare provides for...
Just yes or no on that one. Is it run by the government?
Yes.
Okay. Are you in agreement with my colleague across the aisle that said Medicare has been doing a great job for many years now, in fact 40-plus years?
I think it's delivered essential benefits to seniors for 40-plus years. Yes, sir.
Okay. I just wanted to share a few concerns that have been brought forth to us in the past few months. One of great concern is that the CBO has estimated that the program will be bankrupt in 9 years if left unchanged. So when we get challenged that our attempts to make changes to this program to secure it and protect it for future generations, sometimes I take issue with that. Also,
well, as you know, Congressman, the slowdown in the cost growth was estimated to add a number of additional years onto the Medicare Trust Fund that was provided by the ACA.
okay, well, we'll get in that because we're going to talk about slowdown in cost growth, but we're also, as you stated, we're entering 9,000 new members into the Medicare program each day, or roughly 3.3 million per year, so we're greatly expanding the program, and we're talking about bringing down cost, and it's obvious this is a great thing. Just back from the 70s, you all remember the average life expectancy was much less. We're all living 10 years longer than we were just a few years ago, but that also has to be accounted for. We have to pay for that. That's been occurring. Baby boomers, as we mentioned, are coming through the program now, so we have huge volume issues. Also, it's noted that right now an average family, average couple that makes about $43,000 a year per person has a Medicare tax liability over their lifetime of approximately $100,000, but yet the average utilization for the same couple is about $300,000. So we have a 3-to-1 ratio there, and all those things kind of point towards disaster, especially when we're talking about bringing more people in, yet we're going to reduce cost, and somehow we're going to maintain quality of care. What would be your concerns based on those facts I just gave you?
Well, I think that there are ways that certainly healthcare providers have suggested that we can reduce costs, not tamper with the guaranteed benefits, and deliver better care at the same time. And that's really the strategy of looking at the underlying rise in healthcare costs, whether it's Medicare or the private insurance market or somebody who's paying out of pocket. The trajectory of healthcare costs, paying more for everything that we're doing, continues to rise at well above the rate of inflation. And yet, as you know, Doctor, in the United States, our health results don't show that kind of expenditure. We are not getting the kind of health results we should get. So I think there are all kinds of delivery system. I mean, Congressman Miller mentioned just one
well, I don't mean to interrupt, but we have so little time. One of the things that was
I'd like to get you that answer in writing if I could,
thank you,
sir.
ma'am.
Thank
I
you.
appreciate that. One of the plans when Obamacare was passed on Christmas Eve in the middle of the night was that physicians were going to assume a 21% cut in Medicare. Is that still your intent?
As you know, the President has suggested since he came into office that the SGR has to be fixed permanently. He has proposed again in the 2012 budget that it be fixed. He's got 2.5 years of offset and looks forward to working with Congress to fix it. The SGR, I think, remains as a major barrier to Medicare beneficiaries. Predated the Affordable Care Act, continues to be an issue that I look forward to working with Congress to fixing.
In your testimony on reducing health care costs and increasing quality, you mentioned several times these innovation centers, and you're going to pursue, whenever possible, new approaches that will improve quality of care and lead to savings. As I read through this, I see a lot of assumptions and theories, but I don't see anything based on fact. What exactly are innovation centers, and how can you assure the American people, when the healthcare system as we know now is going bankrupt, that we should just take a blind leap of faith that these things are going to work?
Well, there is one innovation center umbrella, and there are already some programs that have been put out in terms of regulations. So the Accountable Care Organizations is an opportunity for healthcare providers to voluntarily come together and around a care delivery system focused on Medicare beneficiaries. And if indeed there are savings achieved, they get to share in those savings. If there are no savings, it's a net wash. We don't expend additional funding. There's enormous enthusiasm among hospital systems and provider groups for doing just that.
But you'd agree these are unproven and untested theories?
The gentleman's
never
time
existed
has
before.
expired. I thank the gentleman. I'm looking at the clock, and we have less than an hour before the Secretary has to leave, so I'm going to be a little bit more stringent on the 5-minute clock in order to give all of our colleagues a chance to ask a question. Mr. Grijalva, you're recognized.
Thank you, Mr. Chairman, and thank you, Madam Secretary, for being with us. First, an acknowledgement, and then I'll raise a request and just one question. The acknowledgement is to your staff. They've been very attentive to our office, and we appreciate that very much. Some of the questions that came up regarding the waiver process in Arizona, they've been very diligent about communicating with us and giving us the information, and we're very appreciative of that. We've been persistent, and they have been equally gracious, and so I appreciate that. The concern I have is some of the proposed regulatory changes to Head Start and early Head Start. I'm concerned that there could be an impact on dual language children. As you know, this group of children, Latinos in particular, are proportionately low enrollment in Head Start and early Head Start, and as you work through those regulatory changes to diminish fraud and abuse within those programs that should be eliminated, my office looks forward to working with you so there's no unintended consequences relative to the participation of those children that desperately need to be part of that program. So I leave that as a request.
We'd look forward to that.
Question is just for historical purposes, talk about, if you would, talk about what you perceive to have been the original objectives of the Medicaid Act.
The Medicaid Act was clearly aimed at providing health care services for some of the most vulnerable Americans, those who are the lowest income children, pregnant women, the disabled who qualify for Medicaid are primarily the beneficiaries of that program.
Thank you, Madam
And a partnership with state and federal government to deliver those services.
And I asked that question because those objectives continue to be, I think, the guiding principle behind Medicaid. But do you feel that some of the current attempts by the majority in the House to change the program by rolling back eligibility, the block grant process, making it more difficult for those vulnerable populations to get access to health care, both at the state level and at the federal level, how do they mash up with those objectives?
Well, Congressman, I am very sympathetic to my former colleagues who are governors around this country and are in very tough budget times. And balancing a budget is never easy. Medicaid nationally is about 16% of state budgets, and it's always something to look at. We have been very diligent working with states around giving maximum flexibility within the law, working on sharing the best practices. We've got a lot of new governors who have not been in that office before, and we've sent teams into 20 different states to work on what their snapshot looks like in ways that they can save dollars. But I think the administration is continuously committed to providing health care services to those very vulnerable populations. We want to do it in the most cost-effective and, frankly, the most high-value method possible, and that isn't going on in every state around the country. So what we can do is work with states to try and figure out ways to stretch those dollars but provide those essential services, because the folks aren't going to go away. If the federal government decides to shift costs, they just shift onto states, to local governments, and ultimately onto people who end up, on the streets or in a jail or under a bridge because they don't have the support system that they need to stay healthy and stay productive.
Thank you. And in the collaboration with the Education Department around Head Start, because your Head Start is more than just education, it's a whole child program. And one of the discussions I think is important, if I may suggest, is programs like Even Start that extend that literacy to the whole family. One of the programs that Education has indicated that they want to eliminate is part of a component that I think merits discussion. And thank you very much. I yield back.
I thank the gentleman. Dr. Bouchon, you're recognized.
Thank you, Mr. Chairman, and thank you, Secretary Sebelius, for being here today. I'm also a physician, cardiothoracic surgeon for the last 15 years, and I have a bunch of questions, so I want to try to be brief. You stated that Congressman Ryan's plan puts seniors on the open market. Are you aware that it's designed after the same type of health care plan that members of Congress currently have? And would you call that the government putting members of Congress onto the wide open private health care market?
Yes. I mean, and you are in a negotiated federal employee
What I'm saying
health
is
benefit
that
plan, but you don't have a fixed amount of money.
Do I have to go to my local insurance agent and with government money and pick my health care plan, or do I have a book about this thick with a multitude of options from which I can choose that have had, let me finish, that have had negotiated rates that are competitive because to participate in the program as a health insurer, you have to be competitive? This is the same proposal that Chairman Ryan has for seniors, and is clearly deceptive to say to the American people that this is putting seniors into an open health care market, when in fact you know that that's not true?
Well, I do think it's putting seniors, right now they can choose a doctor, they can choose a program, they can do multiple doctor. In an insurance plan, often the doctor is chosen for you, the health plan is chosen for you. I would suggest also, though, Congressman, one of the key differences is that the federal government is a much more generous partner to members of Congress in the federal employee health plan than Congressman Ryan suggests to be to seniors in the plan that they would go into. Their voucher system has a much lower buying power than the federal employees do right now, and it in fact decreases over time according to the Congressional Budget Office. So rather than having the lion's share of the program paid for by the federal government, you would actually have the lion's share of the program paid for by seniors.
Well, I think that's still to be elucidated, and I disagree with that premise. I don't think
that's not
true.
my analysis. That's the congressional budget.
Let's move on. You talked about Medicare savings in the Affordable Care Act being against future growth, and you're aware that the Medicaid proposal to the states for block granting, that what you're calling cuts is actually also savings against an unsustainable growth rate, and is actually what you describe as not cuts to Medicare but preventing further growth, and that the block grants are the same thing, and that it would be deceptive to say that this is actually a cut in the Medicaid program if you're calling it savings in the Medicare program under the Affordable Care Act. It's the same thing, right?
Well, the block grant is really the administration of the program, which, if I understand it correctly, would get rid of the direction to protect vulnerable populations. So states basically could pick and choose who to cover and who not to cover. The fixed
Excuse me,
they have
that ability now, though, don't they?
No, sir. There are some mandatory populations in Medicaid that they cannot drop.
Okay. I want to move on to a different subject. NIOSH is under your jurisdiction in HHS, and under certain responsibilities to the Federal Mine Safety and Health Act of 1977, they are the technical advisor to MSHA, Mine Safety, and recently MSHA has proposed a new rule on coal dust limitations within underground coal mines, and my dad, by the way, was a United Mine Worker for 37 years. We've asked for the background medical information from MSHA and from others, and they've said that that's being denied by Health and Human Services because of patient privacy regulations. And first of all, is that true? Is that the reason why this
Congressman,
committee
I
hasn't
really
been
have
given the
no.
information?
You're saying this is a mine safety standard?
It's a coal dust mine
Right.
safety standard.
But
They're
I mean,
trying to
it's being
cut the
put-
standard down under MSHA. And they
I
say-
would be delighted to
Yeah.
get you a full and complete answer. I really have no idea.
Mr. Maines also told me he would give us the medical background information on that, and we haven't seen
Mr.
that yet.
who?
So and he's saying that that's because Health and Human Services with NIOSH is denying that because it's private health information that you can't give under HIPAA regulation. But you know, we publish medical studies every day with groups of patients.
As I say, Congressman, I will talk to Dr. John Howard, who heads NIOSH, and get you a full answer. I don't know about the mine safety regulation.
What I would appreciate is if we could get the information from NIOSH, giving all of the background on the proposed rule that they submitted to MSHA that justifies this change in a long-standing regulation, which in my view has as a physician, has no medical solid information that it's necessary, and let me say, in my district in Indiana, would be devastating because of the many of the coal mines and others in my state would likely not be able to comply and may have to close, again resulting in a significant amount of job loss. So I'd appreciate that information.
The gentleman's time has expired, and if we could take that for the record. It's a follow-on question.
I'd be glad to. Thank you.
Ms. Woolsey.
Thank you, Mr. Chairman. I thought I'd take the opportunity before I ask our wonderful secretary a question to respond to the gentleman from Tennessee in his question of how the Republicans could be challenged over their proposal to privatize Medicare. The answer is simple, and the answer is when their plan increases the tax cuts for the wealthiest Americans, when oil companies continue to get tax breaks and subsidies, when corporations, successful corporations, pay absolutely no taxes, they are proposing to privatize Medicare, and at the same time asking seniors to take a blind leap of faith that by privatizing Medicare, the private insurers will actually take care of the senior citizens in this country. And that is why there is so much pushback to their proposal. So now I want to go to my question, which has to do with, you mentioned, Secretary Sebelius, a healthy development of all of our children, which of course I support 100%, and I think part of that healthy development is ensuring that when they enter the classroom, they're well, that their mental and physical health is being cared for. Otherwise, these kids can't learn, they can't succeed. Well, last week, the House voted to eliminate funding for the construction of school health centers under the pretense, the Republican bill, that there are other sources of funding laying around this country that can pay for these school health centers. So, you know better than I do that 8 million children lack access to any primary health care, and they need this in order to get through school. So could you expand on the value of investing in school health systems and what that means to the future of our children in our country?
Well, Congresswoman, we're doing two things right now to expand access to coverage for children. One is to take advantage of the opportunity given by the CHIP reauthorization of 2009 to do some very extensive outreach. We think there are likely still about 5 million children who are eligible but not enrolled. So we have a very robust outreach effort going on with school districts and healthcare providers, using sports stars and coaches, others, to try and reach the parents and enroll those kids. But there's no question, I think, that one of the most effective strategies is actually, since schools are often in the hearts of neighborhoods, that a school-based clinic not only deals with the children's health needs, but often the family health needs of the neighborhood. So the Affordable Care Act designated as one of the sites for expansion of community health centers, school-based clinics, which was a recognition that moving into underserved areas, outreach in a very easy way for people to access health services was often very productive, and certainly for parents and children to access services together is very effective. So I think that the funding goal of expanding the school-based health clinic footprint was a wise strategy to make sure that we are reaching into many of these underserved communities and figuring out ways to have accessible health care during the time that families would most likely be able to access health care providers.
So can you think of any pockets of funding where there's excess monies that could be without our funding these school-based health centers?
Well, we are embarked on an expansion of the community health center footprint. Unfortunately, that got decreased a bit by the CR 2011, but we'll continue, I think, to do that because community health centers actually have been proven over and over again to be enormously effective in lower cost, high quality preventive care. And if we want to stop paying 70 cents out of every health dollar on chronic disease, getting to conditions very early, and certainly getting to kids very early. You don't learn well if you're not healthy. You can't study in school if you're not well. So getting a productive workforce starts with having highly educated kids, and kids won't be well educated unless they're healthy.
Thank you.
The gentlelady's time has expired, and I was so hoping the Secretary could identify one of those untouched pots of money.
You seem to think that.
If I find it, I will tell you, Mr.
I'm
Chairman.
holding it to you. Holding you to it. Mr. Kelly, you're recognized.
Thank you, Mr. Chairman. I'd like to yield my time to my colleague, Dr. Rowe.
I thank the gentleman for yielding. Madam Secretary, I think we could have approached, and I read the bill as you did, and it's a hard read, and I think we could have approached getting where we wanted to be by doing exactly one of the things you just said, which if we go sign up the children, 5 million of them, I think was what you said, who are currently eligible for S-CHIP, the people who are currently eligible for Medicaid, and the part about the bill I like a lot is to allow your adult-age children to pick your number, 25, 26, or 27. You could have covered almost as many people doing those two things as you're talking about doing right now with a 2,500-page bill, and it's so complex that nobody understands it. And I think I just want to make that point. I want to get into something that's near and dear to my heart, which is my fear of rationing of health care. The Independent Payment Advisory Board, as you know, was not in the House version of the Affordable Care Act. It did get in the Senate version, and many of my colleagues on the other side of the aisle opposed this. How do I go answer to my constituents and to patients at home that I've been saying that, okay, we're going to get to a certain spending level, and not based on quality, we're going to make a decision about how the money is spent. How is that not going to affect rationing of care in the future when you have more services chasing fewer dollars, which is exactly the train wreck I see coming?
Well, Congressman, the way the Independent Payment Advisory Board is set up is it's 15 individuals who have to have expertise as either healthcare providers or health economists, experts in health, who actually are forbidden by law to ration care. That's part of the statutory framework, are forbidden by law.
Let me stop you right there. Who ends up rationing it is me when I can't give it in the examining room. We have 15 bureaucrats appointed up here that not based on, it's not called rationing, but when you get up to a certain dollar limit and you can't spend any more money, you can't provide the service. So I'm in my exam.
Well, I would share your dismay about a fixed income level, and that's exactly what the House budget proposed for Medicare. We will give you a fixed amount of money, and you figure out what services you get. That is not what the Independent Payment Advisory Board is about. It's about making recommendations for strategies, for new services, for new
I beg to differ,
research.
because in that bill,
and that comes to Congress.
I have-
Congress has the intermediary role with the Independent Payment Advisory Board's recommendations do not go into effect unless Congress chooses to allow them to go into effect.
Well, they do go into effect unless we pick some other way not to spend the money.
Unless you say no.
Exactly, until you
And
pick,
that's-
no, unless you pick some other way not to spend the money. It is going to end up, I mean, I'm certainly very familiar with NICE in England. The National Institute of Clinical Excellence is exactly the same type board. So I think that's what this is going to be. So you would support the IPAB when most of the Congress on the House side did not support the IPAB, including my colleagues on the other side of the aisle. And as a matter of fact, several of them have signed on to a bill to repeal that.
I do very much support the notion that we would have an independent group making recommendations about cost-effective strategies. We have it now, and
an advisory board now.
It is an advisory board. It would continue to be the Independent Payment Advisory Board. The recommendations would come to Congress, and again, they are not implementing medical decisions, and there is no global cap that they're working under. And
Well,
again, I think we're
we have
mixing.
difference of opinion there. A question I have on the mini-med plans. Why were 1,100 exemptions given, and what will happen to them after those exemptions expire? When they can't afford the government-decided plan, what happens then?
Well, Dr. Rowe, the waivers are a part of keeping your plan in at least the time between now and the new marketplace in 2014. Unfortunately, lots of people have some form of coverage that often is not very comprehensive, and they are in a situation where currently in 2011 and 2012 and 2013, something is better than nothing. So the Congress directed us to take a look at the one provision of the plan that talks about getting to an annual limit that would cover comprehensive medical expenses, but suggesting that if indeed a plan can't meet that annual limit without major disruption in the marketplace, between now and 2014, when there is a new exchange, a new opportunity to buy a comprehensive policy at lower costs, that we should indeed look at waivers. And basically 97% of the folks who came in the door, who gave us the documentation saying we can't get to this point because we have such, frankly, low coverage and modest applicability, we decided that some coverage was better than no coverage, and those plans will not exist after 2014.
I would
The gentleman's
recommend,
time
I'll yield back. I would recommend you read this.
has expired.
Evaluation.
Ms. Davis, you're recognized.
Thank you, Mr. Chairman, and thank you, Madam Secretary, for being here today and for your service as well. As you're aware, this week the majority singled out and cut funding to create insurance exchanges where Americans could go to buy affordable coverage without discrimination. And we know in California, and thanks to Governor Schwarzenegger in this, California's been one of the first states, really, to get out of the gate, essentially, to establish the exchanges. So when it comes to states like California that are already in the middle of this process, what kind of difficulties do you see as a result of cutting off the funding that this action would actually cause? And I'm also wondering how the effort would block funding for health exchanges across the country. Would there be some delays, and what impact is it likely to have in reducing the number of uninsured Americans?
Well, Congresswoman, if the provision passed by the House were to be passed by the Senate and signed into law by the President, I don't think there's any question that there would be serious inability of states to move forward with creating a new marketplace, particularly for small business owners and individuals who currently are not only paying more, but many of them are uninsured. We are actually working with governors around the country to set up state-based exchanges, and the resources are being used to do everything from planning to put together IT systems so that you would have a seamless way to come into a market as an uninsured American, with the goal being that every American should have available, affordable health insurance, whether you end up as a Medicaid beneficiary in a private market, in an employer market, that is the goal, to have a fairly seamless system. Defunding the exchanges would mean that we freeze the status quo where more and more Americans every year are uninsured, where insurance rates continue to rise at an alarming rate, and families and small business owners would face either increasing costs or bankruptcy for health conditions which they have no insurance to pay for.
Is it anticipated that there would be just a delay in this of perhaps a few years, or that they would actually be frozen in place?
Well, if the funding goes away, I really don't know. Take the case of California, how indeed California would put together an exchange system that would be operational by 2014. So I think it stops the process unless they find some of that money that we're looking for to fund the school-based health clinics that we haven't found yet. If that appears, we could do this. But absent that funding stream, I think most states would just stop working on the exchange program.
Thank you very much. I appreciate that. I think that we want to, at least in California, I know they are continuing to have these intense discussions, as you noted earlier, in terms of the accountable care organizations and others, and it certainly is impacting those discussions, but we're hoping that they at least will continue to have them. I wanted to also just mention briefly just the disease prevention issues that we're all, I think, very concerned about, and certainly singling out the National Diabetes Prevention Program as well, building on evidence-based methods, giving individuals at risk guidance on how to prevent type 2 diabetes. That is eligible for funding from the Prevention and Public Health Fund at HHS. And so are you seeing that this issue is really going to be established as a national priority in many ways? And how does that dovetail with the work that you're doing with this?
Well, I don't think there's any question that the historic investment in the prevention fund is one that we see yielding significant dividends as you go forward. Again, the snapshot right now is 70 cents out of every health dollar is spent on dealing with chronic disease. And if we indeed can lower the smoking rate, if we can have a healthier population heading into their 50s and 60s by significantly making a dent in everything from diabetes to heart disease, we will have dramatic impact on not only the health costs of this country, but on the health of this country. So lower costs, better health is the goal of the Prevention Fund, and we have some very exciting programs underway across this country in tribes, in farm communities, in cities that are really looking at measurable ways to change behavior, to change practices, knowing that that is an enormously important step. If we can have a healthier population, invest in primary care and prevention, we won't be spending the dollars that we're currently
As a member of Armed Services, it's also a national security issue,
You
of
bet.
course, as we have
You
people
bet.
coming into the services.
The gentlelady's time has expired. Mr. Ross.
Thank you, Mr. Chairman. Madam Secretary, thank you for being here. I want to address health care and jobs, because we note that with the mandates that are in the Patient Protection and Affordable Health Care Act, there's going to be some burdens put on employers here. Specifically in the area of service industries, in the last 10 years, they've been the most predominant, or the most productive types of jobs we've seen in Florida: agriculture, retail, restaurants, hotels, intensely labor, but low profit per employee. And my concern is that when we understand that there's going to be a per employee cost of about $2,000 for health care that's going to have to be provided by these employers may not be able to either continue to keep the employments that they have, and won't be able to expand. And while I appreciate that in the Act there are exemptions for employers with 50 or few employees, my specific question is, would you consider exemptions based on a low profit per employee?
Well, Congressman, we're working within the framework of the law, but my experience is that currently most employers who talk to me, and particularly most employers who are struggling in the marketplace, find health insurance to be the best way to keep talented employees, to
I agree,
expand their workforce.
But when it becomes a cost that exceeds what the market will bear, they're either going to have to release employees or scale back their time.
But right now, they're competing against folks who often are playing on an unlevel playing field. Often the big employers can find health benefits, and they're losing their best workers going down the street or around the corner. I would suggest this creates a framework, and the lowest income employees actually gets help with subsidies in the exchange program that they currently don't have. So it's a kind of win-win.
You think then that the lower employees, the lower income earning employees, but if it's mandated that the employer provide the coverage, and their coverage is $2,000 per employee, and they only have a margin of $2,400 per employee, that margin's been reduced to $400. So these are the businesses, I think, that they're going to be most concerned about the impact of this act.
Again, I'm not sure if we're talking about a large employer who currently...
It would have to be more than 50.
If a large employer is not providing coverage and has an employee who then takes access of the coverage in the exchange, there will be an employer contribution to help pay the taxpayer burden that's being picked up. A small employer will be able to participate in the exchange and have an opportunity to get lower cost coverage for employees that they're not covering right now.
Let's talk about that exchange for a second, because I appreciate the fact, as a former insurance commissioner, I mean, you understand the dynamics of insurance, the markets of insurance, and of course that private companies sell insurance for a reason, to make a profit, but they do so with private capital. That's what's going to back the risks that they insure, and that capital is global. They get it from certain areas. They don't consolidate their risk, and it's actuarially assessed in terms of their risk. But when the government gets in the business of insurance, they don't have that capital. What they have is they have assessments and taxes with which to go after to satisfy any claims. And unfortunately, in the assessment of that risk, it's more politically assessed as opposed to actuarially assessed. So that being said, would you not agree then that when the government gets in the business of insurance, that what they're putting at risk are taxpayer dollars and assessments as opposed to private capital that's spread globally?
Well, I would say that there certainly is more taxpayer dollar involved in the government-based plans, but I would also suggest that private insurers right now participate actively in Medicare Advantage programs. Most states run their CHIP programs through the private market. They are Medicaid beneficiaries, so there is not a line drawn between government plans and the private market.
Well, there is though, and I think that's something that we have to talk about. If we're going to talk about health insurance, because our president said at the outset of his lobbying on this bill that we had a health insurance crisis. And as you know, each state under the McCarran-Ferguson Act regulates their insurance market. But we've got fewer insurance companies in the state of Florida because of mandates in Florida, fewer in Alabama, but yet we have over 1,200 insurance companies that want to sell health insurance throughout this country. Would you not agree then that for consumers, for a market that wants to be based on capital and not taxpayer dollars supporting it, we should open up the barriers and allow for the interstate sale of health insurance?
Well, Congressman, as you know, companies can now sell in any state that they want. They have to be licensed by the state, and they actually have to follow the state laws. But
they have different mandates. In other words, you've got 51 mandates in Florida. You may have 3 in Alabama. You may have so many more in Pennsylvania.
The elected legislators in Florida pass laws that the governor signed.
But I'm talking on a federal level.
The gentleman's time has expired.
Thank you.
Mr. Scott.
Thank you, Mr. Chairman. Madam Secretary, just a quick civil rights question. Is it possible for any sponsors of programs run in your department, private organizations, to get grants to run programs to discriminate based on religion? That is to say, you would have been a good applicant for this job, but we don't hire people of your religion. Is that possible?
To my knowledge, that would violate the civil rights umbrella that we operate under, Congressman.
So that if a faith-based organization were running a program and said we don't hire Catholics, Jews, or Muslims, you wouldn't think they could get funded under your administration, do you?
To my knowledge, no.
Thank you. Under the essential benefit definition of under the ACA. It's my understanding that the Institute of Medicine is currently working on recommendations. In terms of children, the EPSDT program under Medicaid is considered a good standard for care for children. Would it be your recommendation that that be the essential benefit package for children under policies under ACA?
Well, Congressman, the way that actually the essential benefit portion of the discussion is framed in the ACA, there are multiple steps. The Department of Labor has just given us the results of a survey that they did on private market plans, the typical benefits in a private market plan, looking at large employers and small employers. So that's a step mandated by the law. What the Institute of Medicine is doing is sort of step 2, which is looking at the process for putting together an essential benefit package and how often that criteria would be updated. Step 3 is really for HHS then to do extensive listening and outreach to everybody from provider groups to disease groups to patient advocates in terms of getting input on what an essential benefit package should look like, and then a rule will be promulgated. So IOM is actually really more on the process side. They're not doing the health benefits side.
The EPSDT package of benefits, do you consider that something worth recommending?
Well, I think it certainly sets a standard for an effective package for children. And currently, the Affordable Care Act would say that the preventive care that is offered needs to be part of all insurance policies going forward if it's recommended as part of the prevention protocol.
The GOP budget makes certain spending cuts, Pell Grants, education, transportation like high-speed rail, law enforcement, Food and Drug Administration, a list of cuts that total about $800 billion, which they totally offset with extending tax cuts for that portion of your income over $250,000. So that's a complete wash. All of their net savings come from Medicare and Medicaid cuts in those programs. Are you familiar with their little voucher program?
With
the voucher program in the
Medicare
proposal?
Yes, sir.
Does it provide any limit on what the private industry can charge?
Not to my knowledge. I haven't seen the underlying details. Maybe they exist, but I haven't at least seen them. I've seen the outlines.
Do you know if
of
there's
the plan.
any guaranteed issue if you get one of these vouchers that you can actually buy some insurance somewhere?
There is, I think, a limitation on a ban on eliminating people because of pre-existing conditions, but whether or not the dollar amount itself would allow you to buy a plan, I don't know.
If you can't afford it, are there any subsidies to help you buy the insurance?
There are, if I understand it correctly, additional resources available to the lowest income. So there's some sliding scale that would increase the buying power of the voucher depending on income.
And as I understand it, when it starts off, the senior citizens will be paying about $6,000 more of their income towards this policy, and after about 10 more years, it gets up to about $12,000, which would be about half the average Social Security check. Is that right?
Yes, I think there's a dramatic shift of cost onto seniors.
Thank you, Mr. Chairman.
I thank the gentleman. Mr. Gowdy.
Thank you, Mr. Chairman. Madam Secretary, do you believe the Commerce Clause has sufficient elasticity to allow Congress to mandate individuals purchase health insurance?
I try not to practice law without a license, but I have listened closely to our legal team, and I think they believe strongly that the bill stands on solid constitutional grounds.
You would have to believe that, or you wouldn't be able to support the President's health care reform, right?
That's correct.
And because you believe that, you also would necessarily have to believe that Congress can also pass medical malpractice reform, because we would use that same Commerce Clause. And I found it instructive that this administration has not proposed any medical malpractice reform, so perhaps we can take this opportunity and identify what medical malpractice reform initiatives you would support.
Actually, Congressman, that last statement is not accurate. The President asked me during the course of the health care debate to actually use the powers that have been with HHS for a period of time to put in place some targeted programs around the country.
I'm not talking about targeted programs, Madam Secretary.
Sir, they are looking at what kind of medical malpractice actually has the following criteria: increases patient safety, lowers liability costs.
Has this administration proposed specific medical malpractice reform initiatives?
I've just explained to you what's underway right now. They are actually in place.
Give me a specific. Joint and several liability, have you proposed reforming that?
Are you saying, have we proposed the law to change and preempt state law?
Have you championed the cause of medical malpractice reform?
We actually right now have across the country healthcare systems and court systems putting in place malpractice reforms that meet criteria to see and measure what exactly works, because the data is pretty inconclusive whether or not you can increase patient safety and lower liability rates by a variety of strategies. So those are in place right now. They were put in place by our budget with our authority that had actually never been used before by anybody but President Obama.
Do you support reforming joint and several liability?
Do I support preempting state law by Congress? No, sir.
Well, ma'am, and therein lies the issue, right? Because why would that be a preemption of state law in any greater degree than any other federal initiative? You think if we were to reform joint and several liability that would preempt state law?
I think state at a time they have taken on that issue and dealt with it. Yes, sir.
What about a different standard of care for emergency medicine? Would you support?
I have no idea what is the different standard of care. What does it?
There's not. So if a physician is treating someone at a ball game or at a church and doesn't know the patient history, there's no different standard by which their practice will be judged than if they had a 20-year-long history with that particular patient. So my question is, would you support a different?
Sure, I'd be delighted to look at any proposal. I think it's impossible to answer a question when I haven't seen the specifics of what's being talked about and how it would impact. But I'd be happy to take a look at
it. I've read your comments about the debt, and I've read the President's comments about the debt. And I assume you would agree that, because you've said that our debt is stifling. So my question is, given the fact that we agree on that, why was there no proposal for entitlement reform in this administration's initial budget?
Well, Congressman, I would suggest that the Affordable Care Act had a significant step toward entitlement reform with a $500 billion reduction in growth rate of Medicare. That was a big step forward. That was not supported by many in this Congress, but it was the President's first step. I would also suggest that the IPAP proposal, which is part of the Affordable Care Act, is also another big step in terms of entitlement reform that actually doesn't potentially cause harm to our seniors, but makes us make more strategic decisions about cost effectiveness of proposals. We are currently working on proposals around dual eligibles, which is the most significant cost driver in Medicaid, and have a proposal underway in our Innovation Center where 15 states are going to be participating to see if we can really find health strategies that look at that highest cost population. So there are significant steps underway on.
Well, let me ask you this, because the light just went off. If the President's initial health care reform bill was sufficient, why did he then come out with a second budget after Paul Ryan took on entitlement reform? Why did you come out with a second budget that dealt with it?
The gentleman's time has expired. Ms. Hirono.
Thank you, Mr. Chairman and Madam Secretary. I'd just like to make a comment regarding medical malpractice reform. I'd like to see the evidence that connects malpractice reform with lowering of medical malpractice insurance. There's never been, that I don't think has been shown, and therefore, you know, I'd like to see that evidence, because states all across the country have enacted medical malpractice reform and the doctors are still paying. huge premiums for medical malpractice. I think in both education and healthcare, early intervention and prevention are the keys because we save money in the long run, and that's why we should be supporting programs such as school-based health centers and Head Start and quality early education. I've been a major proponent of quality early education, and Madam Secretary, I understand that you had responded to a question regarding the third round of Race to the Top, where your department and the Department of Education will be working together to, I hope, come up with an early learning competition that is kind of like the Early Learning Challenge Fund. And so I'm glad to hear that. I did send a letter to both you and Secretary, our Education Secretary, Arne Duncan, to that point, and I await your response. I want to go on to the Medicare changes that the Republicans would like to propose. During the 2 weeks that I was in Hawaii, I met with hundreds of seniors, and they're very concerned about what the Republicans have in mind for Medicare. For one thing, they're totally astounded that they would have to wait till age 67 before they qualify for Medicare. And I know that they're thinking about when they were 65 and finally got on Medicare health insurance, and I know that they were thinking, what if we had to go 2 years to 67 without any insurance? So then the next area that they're really concerned about is, even if they're currently on Medicare, they care about those who are under 55 who are going to be in this new plan as the Republicans would like to enact. So this voucher system, you responded to some questions about the voucher system, and I'm not clear exactly how that is supposed to work. You're a 67-year-old senior, you get a voucher, and what is supposed to happen? What are you supposed to do to get health insurance?
Congresswoman, I don't pretend to have all the details, but my understanding is it would essentially operate as a subsidy to purchase private insurance coverage. There would be some rules around, as I said, a limitation on pre-existing conditions, so you couldn't be locked out of the marketplace. I don't know that there's any framework of what you could purchase with that coverage. So I assume that companies would put together packages. Somebody would make a choice about whether that package would be sufficient, or I really don't know all the details about how it works.
Thank you, because I'm wondering what kind of packages the private insurance company will put together for 67-year-olds and older with all these pre-existing conditions, even if they cannot deny insurance because of pre-existing conditions. I'm wondering whether all these private insurance companies will stand in line to put together these kinds of programs for 67 years old. And in fact, when I asked that question of the hundreds of seniors that I talked to, they couldn't even, they were just, I know that they were very scared as to how this was supposed to happen. So would you share that kind of concern that I have as to whether the private insurance industry can be counted on to come up with all these different plans that our seniors could avail themselves of?
Well, we currently have some model of the private market in Medicare space with Medicare Advantage programs that have been in operation for over a decade. On average, they are more costly than fee-for-service Medicare, with no perceptible health improvements whatsoever after 10 years. We know that the companies have done somewhat effective jobs of doing a bit of cherry picking in the marketplace. And I think that that's really how you make a profit in health insurance, is that you hopefully get a population that's less sick than more sick. What I think is a great concern is that the amount of money identified as the fixed benefit nowhere nearly matches the potential cost of the services to the average Medicare beneficiary right now, much less down the road, and that buying power diminishes over time.
And I think the seniors across our country are understanding that with regard to the Ryan budget. Thank you.
The gentlelady's time has expired. Mr. Barletta.
Thank you, Mr. Chairman. Madam Secretary, as you know, the PPACA has made significant changes to the laws governing insurance markets and employer-sponsored health care, many of which have the effect of increasing costs for employers, workers, and their families. In an effort to pay for the new subsidy entitlement program, PPACA reduces Medicare expenditures by more than $500 billion and imposes hundreds of billions of dollars in new taxes and penalties, which will likely raise the cost of coverage and increase the financial pressures on employers struggling to grow their businesses and create jobs. For small business home health care providers, this is a huge burden. I have specifically heard from my constituents about the 2.3% excise tax on manufacturers and importers of certain medical devices. How can you justify this tax, especially for small businesses, home care providers who work in rural areas?
Well, Congressman, I think that one of the features of the Affordable Care Act, which is different, frankly, from the Prescription Drug Act that was passed in a prior administration, is that it's paid for. And it does not add to the deficit. In fact, the Congressional Budget Office has estimated that about $230 billion in the first decade and over $1 trillion in the second decade will be decreased from the deficit. So there are pay-fors in the bill. I think the trade-off that you're talking about with a tax on home health manufacturers is that they are also anticipating additional customers along the way. So there is some additional revenue that will be generated, and the return is that they will have access to a far more significant market who will have actually the ability to pay for home health services where they don't right now.
Moving on to another question. In response to questions I've received from small business pharmacists in northeastern Pennsylvania, would you be able to address the rapid refill of prescription medicine? More specifically, many in my community are concerned that prescriptions are being offered in 90-day increments by certain large-scale stores, even though their primary care physician may modify the prescription prior to its expiration. Is this a new process allowed by the Department of Health and Human Services as a result of PPACA?
I can tell you that there's no new process about prescription refills that's part of the Affordable Care Act. I don't know what's causing what you're talking about, but I'd be happy to go talk to our folks and see if they have heard about it or know about it. But there is absolutely nothing that's been put into effect in the year that has any impact on prescription drug refills.
As a former mayor of a city in northeastern Pennsylvania, Hazleton, I've witnessed firsthand the benefits of the human services programs operated by HHS. I'm specifically familiar with and interested in the Community Service Block Grant Program. The President's 2012 budget request includes a $388 million cut to the Community Services Block Grant Program, which, as you know, is geared toward anti-poverty activities. Over the last 10 years, a number of independent studies, including those conducted by GAO, have questioned the program's effectiveness in combating poverty in local communities. In my community, the Commission on Economic Opportunity, an organization committed to combating local poverty, they use the Community Service Block Grant funding to help promote self-sufficiency among low-income populations in Luzerne County. In February, I had the privilege of meeting with the officials of this organization, and I toured their after-school program that ensures children get healthy meals throughout the year. In fact, this organization's food bank, which also assists the elderly population in Luzerne County, has provided over 4 million pounds of food to 160 agencies over the past year. Now, while I've seen the good of this program and others like it, I am supportive in finding ways to make the CSBG program even stronger. What changes do you think the committee should make to the Community Service Block Grant Program to make it more effective, and when was the last time this program was evaluated?
Congressman, first of all, let me say I would look forward to working with you to do just that. I think that there's no question at all that the reduction in funding that's being proposed is not one that would have been proposed if the budget times were better. Let me start there. I also think that it's been our experience that the funds administered through the state and to a variety of community action agencies, some are very competent and effective, others have been less effective. And we are currently in the process of reviewing, knowing that we're likely to have diminished resources, what are the kinds of criteria to put in place that would actually drive the best practices around the country, because I would say that the program impact has been really mixed. But we would look forward to working with you around what that strategy looks like.
Thank you. The gentleman's time has expired. Mr. Tierney.
Thank you, Mr. Chairman. Madam Secretary, thank you for being here today. Let me just start with a couple of very brief questions about low-income home fuel assistance. On that, can you give me an idea of when that money is going to be released to the states? Because we have reports of people fearing the loss of their utilities if that money doesn't get released to the states so that they can distribute it.
I'm trying to get my experts back here to give me a...
Well, if you could give me that answer, if you can't give it to me right now, if you could get that to us when you can.
Well, we'll get it to you, sure. And what we've tried to do up until this moment, I can tell you, is put the money out the door as soon as we had the authorization. So I can get you the precise date that we'll try to push the rest of the FY11 money out.
I appreciate that. And the President's proposal for the fiscal year 2012, he proposed a 40% cut in those funds, premised on the idea that the costs were going to be somewhere around somewhat lower in the future. Now the costs are back up to what they were in 2008 for oil, and they're increasing for gas. Are you going to revisit that decision?
Well, Congressman, as you know, the budget has been proposed. We would look forward to working with you. I know it's a vital program. It was a snapshot that looked like we were in times that could return to the historic level, but I think we need to look at the challenges and that impact on particularly the low-income families who rely on it.
We would appreciate that. Thank you. We'll work with you on that as well. Just a quick comment on the medical malpractice stuff. We do quite a bit of looking at that. Are you aware of any study at all that indicates that even if all the medical malpractice reforms proposed went into effect, it would do anything more than save a minuscule fraction of the national health care costs?
Well, I think right now malpractice premiums are far less than 1% of any health care costs. And unfortunately, the data is very erratic. States that have put in place every kind of tort reform possible and states that have no tort reform possible seem to have about the same malpractice rates. So there doesn't seem to be a corollary impact between the legal framework and what docs are paying. It's difficult to assess and measure what defensive medicine costs. It's also, I think, very difficult to measure what a lack of patient safety costs. And those, you know, we talked about errors that occur in the medical system right now, which kill about 100,000 people a year. So I think that balance is very critical.
And it's a state-regulated insurance industry. Is that correct?
That's correct, sir.
And that, last thing, that I do see reports, however, that draw a correlation between the return on investment from reserve funds by insurance companies and the increase in premiums. I think that would be a more appropriate place to look for some correlation. Is that correct?
Well, I think the malpractice market has been very lucrative.
It has indeed. The community health centers. In H.R. 1, the original proposal for the continuing resolution, there was a proposal to substantially cut the funding for those centers. Would have closed about 127 centers if it had been passed. It would have cut off about 11 million participants. It would have caused thousands of people to lose their jobs. In the end, there was a much less severe reduction in that. But can you talk to us just for a second about the value of community health centers, what used to be a bipartisan priority? I remember working with President Bush on this as well, how important it is or isn't to our system, and what attention we should be giving to those centers.
Well, I don't think there's any question that the current community health center footprint is an enormously important infrastructure for low-cost, high-quality delivery of health care in the most underserved rural and urban areas. The training of docs in community health centers is a terrific training ground, and over again they are proven to be enormously effective. The trajectory that this administration proposed was actually moving from the opportunity for 20 million Americans served by community health centers to 40 million Americans, starting with the investment in the Recovery Act and moving on through the Affordable Care Act. That's taken a little bit of a bump in the road, but we still feel that having an expansion of community health centers and matching them to the most underserved area is the most effective, most efficient, most cost-effective way of getting high-quality health services to people who now have limited access to doctors.
Thank you. And I'll just close with the notion that the Medicare and the Affordable Care Act reduced monies. I think we've made the point. We want to reiterate it. What it did was slow the growth of costs. And I note that in the Republican proposal, they don't change that fact. They like the savings of those costs, and they understand that that was, in fact, addressing an entitlement by slowing the growth in costs without reducing the number of defined benefits. Is that correct?
Well, that's absolutely correct. In fact, the language in the bill, as you know, reemphasizes the fact that no defined benefit can be tampered with. So, in fact, the Affordable Care Act increased the benefits. So seniors now will have the donut hole closed over time, not fall into the gap in drug coverage. We'll have an annual wellness benefit. We'll have preventive care without copays. So there are some significant enhancements as part of the guaranteed Medicare benefits, along with the reduction in the costs over time.
Thank you.
The gentleman's time has expired. Madam Secretary, we have two final questioners, and we'd like to allow both of them to have an opportunity. So, Mr. Wakita, you're recognized.
Thank you, Mr. Chairman, and thank you, Madam Secretary. I am one of the last questioners, so hopefully we'll be able to respect your time. Appreciate you being here. With regard to this medical malpractice that has popped up here lately, of course you understand that, at least for many Americans, many of us that I represent, it's not the premium that the doctors pay that's the concern. It's the defensive medicine costs. And you indicated that it might be a hard cost to determine. I don't know if I agree with that. I think we've been able to determine in this country a lot of other things. And my doctor colleagues, including the two that sit on either side of me on this committee, when I asked them before they left, they say it could be anywhere between $100 and $500 billion a year in defensive medicine costs. And they do this every day, as specialists at least. So I wanted to let you know about that. And then as a member of the Budget Committee, in case you're asked these things again, I need you to know that the plan, because you said that you saw some outline of the budget, but not necessarily the details. It's not a voucher. It doesn't go to the person. It goes to the insurance companies who would want to participate. And on our federal plan, as Dr. Bouchon was explaining, there are at least 9 or so different kinds of plans, depending on what part of life we're in, that we can choose from. And to the extent that Congress is a microcosm of the people generally, I really don't understand why that couldn't work.
Well, part of it is the federal government is paying 70% of the cost of your health care right now. And assuming that you're in the federal employee benefit package, this plan is significantly less generous for a more I would say, likely to be sick population, more difficult conditions, older, and the growing, it doesn't rise with the cost of.
No, I think that wasn't in your outline, because if you look at our plan, we are calling for a needs test, and we are calling for a risk test. Those of us who are sicker would get more of it. Those of us who need less of it because of our stage in life or state in life would get less of a subsidy. So,
but again, according to the Congressional Budget Office, it's significantly less buying power than Medicare provides right now for seniors, and it actually, the buying power decreases over time, again, according to the Congressional Budget Office, and they're saying 10 to 15 years out, 70% of the costs of health care would be borne by the senior themselves, not
right. But you come from state government like I do. I was part of the executive branch of the Indiana government, and so, you know, I come to this place not believing everything CBO says, especially how they are chartered. They are only allowed to look at exactly what's put in front of them. And so we both know that that's
well, this was, if I understand it, the specs given to them by the House Republicans, by Congressman Ryan, those were the only specs.
As set forth in a previous act that they're chartered by, and we can argue around all that, but
no,
we both know that we have a program that works for the Congress, and we both know people clamor and talk about how good we have it here in the Congress. And to see us argue now against that for the rest of the American people, you know, I don't understand. Let me get on with something of my time.
Well, again, there's no evidence at all that Medicare Advantage, which operates through private market strategy, gives seniors choices, is either more cost-effective or more health-effective for seniors. In fact, the cost is significantly higher and the health benefits are lower.
Issue that you didn't, as Dr. Bouchon was explaining, you weren't seem to understand the details. Here are some of the details. Joe Main is the Assistant Secretary for Mine Safety, not under your jurisdiction, of course, but he apparently used something from a set of data from NIOSH to go after the coal dust rule and to propose some things. Now, he, on March 28th, wrote your office and said, please release this data. It's not mine to release, but please get this to this committee so we can, and the stakeholders involved, so that we can participate better in this rulemaking. And so what I want to ask for you on the record, I think you said it with Dr. Bouchon, you'd be helpful in trying to get that, right?
Absolutely.
Okay.
I
So
don't
you
know
give me-
about that issue.
Understood. But again, sharing your executive experience, I can tell you got people behind you that you can easily turn around to and say, what date can we get Congressman Rokita some answers on this? Can you tell me how long?
I can't give you a date certain until I know what it is that we're looking for, but I can guarantee you all of us heard the question 4 or 5 times. We understand there's a letter, and I'll try to get
You can get me a date as to when you'll get me to answer.
Sir, I really don't know what it is that we are being asked to produce. I will get you an answer very quickly.
Yeah, just an answer about when it would come. That's simple.
Oh.
Yeah. So if it was me in your seat, I'd say, 24 hours or so, but give me whatever answer you can. Just tell me when. You'll give me an answer on when this stuff might come.
I don't know what it is that you're looking for, so I can't possibly give you, I'll give you an answer about when it will
Yeah,
come.
that's what I mean.
Within a couple of days, once I can talk to
That's
Dr. Howard.
That's all I'm looking for. I appreciate it.
The gentleman's time has expired. Mr. Hinojosa, you're recognized.
Thank you, Mr. Chairman. Secretary Sebelius, thank you for joining us today to discuss your priorities and to respond to the Ryan budget proposal put forward by the Republican Party. I am troubled by the Republican plan to end Medicare as we know it. For my constituents in South Texas, the Republican plan would be disastrous. It would force seniors into the private sector for insurance, and it would force them to spend more and more of their limited income on health care. In regards to our nation's youngest, just yesterday I sat down in my office with a pediatric anesthesiologist struggling to treat some of my district's most impoverished and vulnerable youth, many of which are Medicaid beneficiaries. The Republican plan slashing Medicaid is not the answer that providers or children are looking for, because it would unjustifiably hurt access to quality care. I wish to ask 2 questions. As the former insurance commissioner and governor of Kansas, you understand the heavy burden of health care costs on seniors and families with children in poverty. What is the Obama administration doing to help bear that burden, and what new strategies are being pursued for helping our most vulnerable populations?
Well, Congressman, I think the President shares your concern about the access to care for the most vulnerable Americans, and that's why I think he has stated an opposition to the block grant idea with a fixed amount of money available, knowing that you can't predict recessions, you can't predict disasters, and you certainly can't predict how many people are needing to access programs at a difficult time, as we've just seen in this country. The same would be true for Medicare. To change from what is a guaranteed benefit program to a fixed income situation, I think could provide an enormous cost shift onto seniors at a time where they could least afford it, and make it very, very difficult to access life-saving care.
With respect to Head Start, HHS is in the process of implementing the new performance standards. Seeing more parent and family engagement in our early education services is very important to me. Will you please tell us how these performance standards will strengthen the Head Start program?
Well, Congressman, we're taking the report on program integrity very seriously, and we think it's important that The Head Start grantees follow the law, follow the guidelines. In addition, we're working closely with our education partners to look at the range of skills that children need to be school ready, and making sure that in addition to social development that there's a curriculum development as part of the Head Start program. And certainly the parental involvement piece, which has been always a hallmark of Head Start, is something that is going to be strengthened and very critical moving forward.
Mr. Chairman, thank you for letting me ask those questions. I yield back.
I thank the gentleman. Timing is near perfect. I'd like to thank the Secretary for being with us, spending the time with us today, and putting up with the interruptions from the votes. I'd like to recognize Mr. Miller for any closing comments he might have.
Thank you very much. I want to thank the Secretary very much for being here, I just want to say, after listening to your explanations and your defense of the Accountable Care Act, and when I see the excitement and the response across the medical community and the employer community to this legislation and to the initiatives that you've started to roll out, it's really very, very encouraging. After the Accountable Care Act passed the Congress, President Obama called me and said that I should be very proud as being one of the chairs of the committees for the major jurisdiction on this legislation. I obviously told him I was very proud, but listening to your defense and your explanations here and your initiatives on behalf of the law and the government, I'm even more proud than at that moment when we passed this legislation, because this is the kind of implementation that we were hoping, and to see now hundreds of thousands of employees being offered insurance by small businesses because of the tax credit for the first time being reported all over the country is really very exciting for those individuals and their families. So thank you very much for your appearance here before the committee.
I thank the gentleman. It's always interesting. He and I must always talk to different businessmen and women and different care providers. I'm not yet seeing that excitement on their part, and I don't share that excitement with him, but I again very much appreciate your time and your testimony here today. There being no further business, the committee is adjourned.